Hello, assalamu alaikum everyone. Welcome to the EBM crash course. I'm Salsabil Haque. I'm currently a fifth year medical student, and I'm going to be giving you this crash course. And basically, for EBM, which is evidence-based medicine, the course is very, very logical. It's a very simple course. I know it can seem very confusing because of the way some things might be worded or because most of us might not have paid attention during the lectures, which is what I think the main reason is. However, if you really go through the lectures, give it one read, you'll see that the course is actually very, very easy. Okay, so what I'm going to do is that once when I started to kind of prepare for this lecture, what I realized was that I'm essentially just copying and pasting the slides. So instead, what I did was I tried to combine all of the slides into one, and obviously I changed a lot of things here. I changed a lot of things to make the explanations easier and everything. But the format, I tried to keep it original so that you don't have to get used to a new format. And it's essentially everything that is in all the 16 lectures just condensed into one PAL session. I hope that makes sense. All right, so let's go ahead and get started. As I said, evidence-based medicine. Before, just let me give you some context. So, evidence-based medicine is basically what the general idea is that anything you practice as a doctor, you need to have evidence behind it. What does evidence mean? It can be in the form of research articles, case reports, case series, randomized control trials, systematic reviews, whatever, whatever. Right? So let's go ahead and get started. All right. So these are the lectures basically, and that's our agenda for today, and we're going to be covering everything, inshallah. All right. So first of all, we'll start with eminence-based medicine versus evidence-based medicine. Okay. So eminence-based medicine or traditional practice it's what we used to practice before. Okay. And this is basically reliant on clinical experts and their opinions versus what we practice now, which is evidence-based medicine. Evidence-based medicine, I kept the definition as it is from the slide because that is what comes in the exam, verbatim, word for word. So, evidence-based medicine is an approach to medical practice that emphasizes the integration of clinical expertise, patient preferences, and best clinical evidence. Okay? So, what does that mean, or how do you remember this? For example, you're a doctor and you're in the clinic. Okay, so in the clinic, what do you have? You have yourself, you have your patient, and you have all the knowledge, right? So how do you, make this evidence base? You have to take into account your clinical expertise, the patient's preferences, and the best available evidence. Okay, so just imagine yourself in the clinic. It's you there, it's your patient there, and it's your computer there. So you get your evidence from the computer, you get the best evidence, then you get the patient preference from the patient, and you get the best clinical expertise from yourself. Okay? All right. Now, so that's the difference between evidence-based medicine and eminence-based medicine. Okay, and that's a very common question. All right, then this is the framework of the entire evidence-based medicine course, and all the following lectures kind of follow this pattern. So, to practice evidence-based medicine, you have to follow 5 key steps. What are these 5 key steps? You have to ask a question that is answerable. You have to acquire the best evidence in order to answer the question. Then you have to, after you gather the evidence, you have to kind of critically judge these evidence. Are these actually accurate evidence, or are they falsified, or do they have other factors which they're not taking into account, right? So that's what appraise means. You hear this word often in journal clubs. So as in like critical appraisal. Okay, so you have to critically appraise any kind of evidence that you come across as a student or as a doctor. This is very important because otherwise, you will not know what's right from what's wrong. Okay, then you apply the process um, into clinical practice. And as you go along, you assess your performance and the process and you start all over again. So this is a loop, basically. Okay, so you start by asking and you end by assessing your performance. And if there is anything wrong, you then again go back to asking why it's wrong or why anything is wrong. Okay, all right. So, just to kind of give you a visual representation, how do you remember these 5 key steps? Because the entire course kind of depends on these 5 key steps. All right. So first, you start off with asking. So let's say Let's say now it's winter. I'm feeling cold, okay? So I'm asking, or let's say this girl, she asks, how do I keep warm? So that's her question. That's the first step, right? She asks. Then she goes on the internet and she searches up how to keep warm. Okay, she acquires information from other sources and she kind of sees what is already been published regarding this. So let's say like four key ways to stay warm during this winter or whatever, like any kind of websites that publish research for the topic that she's looking for. Okay. Then, after she acquires information, she critically judges the information. So now she thinks, okay, so I saw this on a website. How how do I know that it's credible, or how do I know that I should believe this? Okay, and then after she thinks, after she sees on a website, let's say wearing a jacket keeps you warm. Okay, so now she's like, okay, I think this is from a credible source and I think it might work. Now she will apply this. She will go to the store and she will get a jacket. Okay, so this is applying the information to a clinical practice. Then, after that, she will wear the jacket and she will assess her performance or the jacket's performance, let's say. And um, let's say the jacket feels itchy. Okay, then she'll go back to the first step, which is ask. Then she'll be like, okay, why does this jacket feel itchy? Or how can I stop this from feeling itchy? Right? Then she will acquire information on that, appraise, apply, and assess. Okay, so again, first step, ask, acquire, appraise, apply, and assess. These are the five very important parts of any evidence-based medicine practice. Okay, so this is very, very important. And the when you study the lectures, or if you go through the lectures, you'll see that the order of the lectures actually also follow these five steps. Okay, so we know that evidence-based practice, it is one of the best ways to practice medicine, and it's more up to date. It's a more up to date way to practice medicine compared to eminence-based medicine or a traditional practice. And so, however, there are a few limitations. And the limitations were actually measured quite a few times throughout the course, but I tried to make it all into one. So limitations are, for example, limited access to quality evidence. For example, if a patient is sitting in front of you, you don't know, and they're asking you, let's say, what is the best lifestyle management for blood pressure? And you know the best medications for blood pressure, but sometimes they ask you for non-pharmacological treatment, right? So sometimes you don't know the exact information and you don't know what's the most up-to-date kind of lifestyle modification, let's say. So if the patient is sitting in front of you, you don't really have much time or even much access to quality evidence. Or someone in very rural areas, they might not have access to quality evidence. So that's going to serve as a limitation to evidence-based medicine. Okay, then there might be conflicting research findings. We all know this. Different research might say different things. Limited time, limited resources. Research is costly. It requires manpower and things that a lot of countries or a lot of different economical statuses can't afford, right? Then you need to develop new skills for research. You need to know how to critically appraise. You need to learn biostatistics in some cases, literature reviews, etc. There might be limited clinicians' access at that point of care, as you know, in rural parts of the world, or just even because of time shortage, there might be limited access. And research is constantly changing. So some evidence that is valid now might not be valid tomorrow because of some groundbreaking research that finds out that something has a serious side effect that we didn't know about, right? So these are some limitations. Feasibility is another limitation. So these are some limitations in evidence-based medicine. Again, the general kind of theme throughout this course is that it's very logical if you go through the slides once, or even if you go through my presentation once, which is a condensed version of all the slides, um, you will basically be able to answer any question. It's very logical, actually. Okay, now there's something else which is also a very good practice of medicine, and it's called personalized medicine. So more and more as we progress and as we use, genetic testing or AI or things that kind of tailor a person's experience and how they receive treatment and, receive treatment and also kind of clinical guidance, we go towards personalized medicine. So what is that? Again, study the definition. It usually comes verbatim, the definition, and you need to be able to select the right one. So it's a medical approach that tailors the prevention, diagnosis, and treatment of disease to individuals based on their unique genetic makeup. Okay? So instead of saying that someone with let's say a dyslipidemia, should be given statins. You can also measure the genetic makeup of that person and make sure that the drug that is given to them is not contraindicated for them, or the drug that is given to them is not resistant for them because of certain genetic mutations that they might have. Okay, and that's the main purpose of having personalized medicine. Okay, so I have a lot of questions. Some of them are from the slides, some of them are from the 15th batch. And I've actually included, I think, 90% of the questions from 15th batch. The other 10% I didn't include are the ones that are either very obvious and I have them in the text in my slides, or, yeah, just very obvious, honestly. Okay, which of the following is the first step in the EBM process? We said that the first step is going to be to ask a focused clinical question. Okay? All right. Also, I'll try to take as less time as possible. I really do not think this course requires a lot of time or a lot of effort. It's a very logical, at the risk of repeating myself. Okay, anyway. So when doctors consider research before recommending a treatment, they're practicing which of the following? They are practicing evidence-based medicine. Okay? All right. So doing research before treatment means that you're practicing evidence into your clinical practice. Okay. Which of the following is a contemporary term for the application of clinical epidemiology? It is going to be evidence-based medicine. This is a very roundabout way of saying things, and I was there in the 15th batch, I believe, but it just means evidence-based medicine. It's a contemporary means a modern term. Clinical epidemiology is like, research done on the population clinically, and using that or applying that is going to be evidence-based. Okay, then we move on to the next lecture, which starts off with the first step of the framework, which is it is ask, right? So when you ask a question, you should follow the PICO framework. What is the PICO framework? It is going to be population, intervention, comparison or control, outcome, and some scholars add a T, which is the time frame. Okay, so population is going to be the population you're interested in. It could be pediatrics, it could be geriatrics, it could be population who smokes, teenagers who vape, it could be anything, right? So it's the population that you're interested in and the population you're going to be taking a sample from. Okay. Intervention, it is the treatment that you're going to provide. You should know that not all studies are interventional. However, all studies have an intervention in their question. Okay? So it's no, actually that's not true. Not all studies are interventional, okay? So intervention is kind of the intervention or treatment that you're going to provide, and comparison or control is what you're going to compare the population to. So that could be someone who's not getting the treatment or someone who's getting another treatment, right? And then outcome. Outcome can be anything. It can be measuring the rates of lung cancer, or it could be as simple as um, sleep hygiene, or something very simple to something very complex, but anything that you're trying to measure. So it's going to be something that's measurable. Okay? All right. So consider the following PICO scenario. A primary care physician decided to encourage teenage smokers to quit smoking. Okay? So she convinces her colleagues to help her. She searched for evidence that shows the effectiveness of brief intervention techniques. What is the P here? The P is going to be teenagers who smoke. Our population is not non-smoking teenagers. We want to encourage smoking teenagers to stop smoking, right? So our population here is going to be teenagers who smoke. All right. Now, this question, let's say, in emergency department, patients with low risk chest pain, does, sorry again. In emergency department patients who have low risk chest pain, does routine advanced imaging for all patients compared to standard risk stratification reduce the chances of a missed myocardial infarction? What this essentially is saying is that if you're working in the ER and a patient walks in, and they're complaining of a chest pain, but their risk of developing a myocardial infarction is very low. Would you still do routine imaging, advanced imaging, okay? Would you still do routine advanced imaging, such as like an angiography or something, for the patient to reduce the chances of a missed myocardial infarction? Yes or no? Is that better or no? Now, you might say that, okay, this follows the PICO framework. So the P is patients with low risk chest pain, and what do you call it? Uh, I, intervention, is going to be advanced imaging. Then you have the C, which is comparison is going to be risk stratification standard. And the O is missed myocardial infarction or reduce the chances of missed myocardial infarction, right? So this follows the PICO framework. But you might say, sure, but in real life, would you really be able to do this research? No, because how can you do advanced imaging for all patients who come in with low risk chest pain? You simply can't because it will require a lot of resources. A lot of advanced imaging will take up a lot of rooms that are not available in a lot of hospitals, most of the hospitals actually. It's going to be very expensive for the patient. And so this brings us to another important point when asking a research question is the feasibility of research. Okay? So some additional considerations that you must have in your research question that is feasibility, whether you're able to perform the research question in terms of available resources, data, and ethical considerations. Okay? Ethically, if you are making all the patients who have low risk chest pain undergo advanced imaging, are you not taking the resources away from people who might need it more? So that is a bit ethically challenging, right? So that's one of the things that you can consider, which is feasibility. Then you have relevance. Relevance is going to be making sure your research question is relevant. So let's say you can't do, for example, what happens to SLE when someone goes to Mars? Who cares? It's not really relevant to to the wider population. Okay, and you must not ask leading questions. What does that mean? So something that kind of almost points you to the answer. So you don't have you don't experience any side effects from the medication, do you? It kind of tells that I'm not supposed to experience any side effects. Okay. Okay, and then remember that well-structured research is the foundation of successful medical project, and this might come as an MCQ as well. Okay, so identify the components of PICO. In patients with recurrent furunculosis, do prophylactic antibiotics compared to no treatment reduce recurrence of furunculosis? What is the P? What is the I? What is the C? What is the O? So the answer is going to be C here. So patients with recurrent furunculosis, it's going to be the P. Then the intervention is prophylactic antibiotics, comparison with no treatment, and the outcome is going to be reduce or reduction of recurrence. Okay. Now, what is the purpose of PICO? To help formulate questions, to help critical appraisal, or to help with step 4 of the EBM process? It's going to be to help formulate questions. Very obvious. Okay. What is the step 4 of the EBM process? Can someone tell me? I mean, it's a recording. You can't really tell me, but it's going to be, I believe, apply. Yeah, apply and then assess, right? Yeah, so step 4 is apply. Now, there are some more limitations here in EBM. So one of them is publication bias. What does that mean? When we want to practice EBM, we want to find a result that, we want to find a research that has results, right? So this might kind of push researchers to publish results or publish research which has positive results, okay? Or which has statistical significant difference. So only if a result, for example, let me give you an example before kind of confusing you and myself more. If someone says that um, I have lung cancer, no, let me think. So for publication bias, let's say one research found out that vaping causes lung cancer. Okay? They are going to be very excited to post or to publish their research, right? However, if there are 10 other research papers who did the same kind of study, vaping causes lung cancer, and they did not find any significant difference, they might be hesitant to kind of publish the research because they're going to be like, okay, we're not even, we might not get funded for this research. This research is not going to be invited to any conferences. It's not really any statistically significant research, right? So that's why they might not be willing to publish. And then what happens? People are going to read that vaping causes lung cancer. So they're going to see the one research that coincidentally found a positive correlation and not the 10 other research papers that couldn't find a correlation and did not publish them. That's not what people are going to see, right? So this causes a bias in publication. And it kind of forces people to only produce data that are statistically significant and are positive. Okay, so that's what publication bias is. That's why it's very important to know that even negative results are good results because we need to know what does not have an effect, and we need to know as much as we need to know what has an effect. Okay, then there might be some issues with RCTs. RCTs, randomized controlled trials, that is, it's one of the most highest forms of clinical evidence. However, RCTs might be very expensive to perform. They might need a lot of what do you call it? Resources and time, and as I mentioned, all of these things before, and they might have some ethical issues as well. So let's say they found a drug, statins versus another drug. Yeah, they're doing a result study, let's say, for dyslipidemia, and they want to see whether statins have an effect better than no treatment in reducing their risk of cardiovascular diseases. Okay, so the treatment group that is getting statins is good, but the treatment group that is not getting statins is kind of being deprived of a treatment, right? So that kind of raises some ethical considerations. Can you withdraw a treatment from a treatment group, sorry, from a control group? Just for the sake of the randomized control trial? Is that not going to be unethical? So we need to take that into account when we're doing randomized control trials as well. So, and then the rest it's very obvious, very logical. Okay. All right. Now we're moving on to the hierarchy of evidence. So there are many different kinds of research papers, and that's a very high yield topic where I've seen a lot of questions come from. And it's kind of a pyramid. However, you need to know that this pyramid is not really agreed upon by everyone. Okay, so some people might say that RCTs is the most highest level of evidence than systematic reviews or meta-analysis. But this is like the most consensus, but I've seen other opinions as well. Okay, so what is important is that at the bottom of the pyramid, you have expert opinions because we don't practice evidence-based medicine anymore. Okay, so expert opinions, editorials, anecdotal evidence, these are all at the bottom of the pyramid. They are not that important of an evidence. They're obviously very important, but they compared to the others, they're the least. Then we have case series and case reports, which focuses on individual cases. Then we have cross-sectional studies. We'll go more into that. Cross-sectional studies are studies um, which kind of shows an observation, which makes an observation um, in a certain amount of time, in a certain point of time. Basically, it's a snapshot study. Then you have case control, which has a comparison between a case and a control, and you go back and see whether they have any differing exposures. Then you have the cohort studies, which are the opposite. So you take two groups of people and you measure two groups of people with different exposures, and you see whether they lead to a certain outcome that you're going to measure. Okay, then you have randomized control trial. I'll go more into these. I'm sorry if I'm confusing you now. Randomized control trials, which are trials, basically, they're interventional study where you actually give a treatment. So there's going to be a control group and there's going to be a treatment group. Treatment group receives the treatment, control group doesn't. And then you see whether the cause causes the effect or not, or whether you can treat them. Then systematic reviews and meta-analysis, they're at the top of the pyramid, and there are basically reviews. And they collect a lot of evidence together, a lot of research together to publish a review that the doctor can easily read. Okay? Now, well, let's go through them one by one. So, systematic reviews and meta-analysis. As I said, there are reviews which are done in order to kind of comprehensively combine a lot of research together. Literature reviews are the simplest among the reviews that there is, and it's usually done by searching one database. Okay? Okay, so this is, for example, a literature review. It is done by searching one database. Then a systematic review is done by searching multiple databases. So PubMed, Scopus, Embase, Medline, whatever else there is. And then meta-analysis is if you do a statistical analysis based on those research results that you've found from all the databases, that's going to be a meta-analysis. Okay, so meta-analysis is a statistical procedure. That's the only difference between systematic reviews and meta-analysis. Now, know these two lines. Basically, they have a systematic reviews have a rigorous criteria for inclusion of articles, and Cochrane Review has a lot of systematic reviews. So these are two things that have appeared in the MCQs, and just something to know, basically. Okay, now then we have cohort studies. Okay, so cohort studies. They can either be retrospective or they can be prospective. But what are these studies? What do? You compare a group with a given risk or exposure to a group who did not have that risk or exposure to see whether this risk increases the likelihood of developing a disease. So you either follow up with a patient who has a certain risk factor, let's say smoking, let's say obesity, and you follow up with them prospectively, which means follow up with them in the future and see whether they develop um, heart attacks, let's say. Okay. Or you can go backwards. That's going to be a retrospective cohort. Okay. So you're going to go backwards and you're going to see whether or not, like, you can have yeah, basically, like, you can go back in time and do the same process. So it can either be prospective or retrospective. Prospective is in the future, retrospective is in the past. Okay, so cohort studies, keyword is risk or exposure. Okay, so any option you see with risk or exposure, it's going to be cohort and not case control. Which brings me to my next point, which is case control. So, case control study compares a group of people with the disease to a group of people without the disease. How can you remember this? It's in the name. It has to have a case and a control. So cases are people with a disease, and control is the people is are the people without the disease. So, for example, you have a group of cases and you have a group of controls, and then you're going to go back and see whether they have certain exposures. So, continuing with our lung cancer and let's say vaping, um, you have 5 cases of lung cancer, 5 cases without lung cancer, and sorry, you're going to go back in time, check their patient records and or ask them basically. You're going to go back in time and see whether or not they vaped. Okay? So your outcome here is going to be the exposure or the risk factor. The disease is already established. I hope that makes sense. Okay? And one another thing that I saw in the MCQs is that you usually for case control studies, you calculate the odds ratio. Okay, so if you have cases and controls, you're going to find out um, what are the odds that they have more vaping than the other group. Okay, so for cases with lung cancer, what are the odds that they have smoked more than the odds that the non-lung cancer group smoked? I hope that makes sense again. Okay, so usually they calculate odds ratio. And how do you remember this? You remember this by this kind of sentence that control the case in the OR. Okay? All right, so case control, odds ratio. All right, cross-sectional studies, as I mentioned, it's kind of a snapshot kind of study. It measures risk factors, disease, frequency of disease, prevalence, keyword prevalence. I've seen that a lot in the, uh, what do you call it, exam as well. And risk factors, prevalence, frequency of disease at a particular point in time. That's very, very important. Okay? All right. So, most important thing to do is to pilot the study. Again, these are from the MCQs. So, most important thing to do for a cross-sectional study is to pilot the study. What does this mean? You send it out to a few people, you assess their responses, and you see if your form is working, if your questionnaire is serving what it's supposed to serve. Um, yeah. However, for online surveys, again, this is an MCQ that I saw. For online surveys, you need to keep into account convenience sampling. What is that? Convenience sampling is what happens in Al Faisal a lot. So when we do research here, we kind of send it out to mostly Al Faisal students, right? Even sometimes when our population is the general public. So because our population is the general public and we only send our sample to Al Faisal mostly, this can cause a convenience sampling bias. What does that mean? Most of our population have similar characteristics, which might cause the data to skew in a certain way. Okay, so it might make the age group the same. So we know that Al Faisal mostly people are, almost all of them are university students. So the age range might all be 18 to 25. So their experiences with life is going to be different compared to someone who is 18 to 25 but is in somewhere else or in a different age group. Yeah, so that can cause some bias. And that's what convenience sampling means. Okay, then we go to randomized control trials. So these are trials involving humans that compare the therapeutic benefit of a treatment and a placebo or active placebo. Now, what is active placebo? Active placebo is something that is not the treatment, but something that has a similar side effect compared to the treatment. Okay, So if you have a treatment group and a control group, you are going to give the treatment group the drug, and you're going to give the control group another drug or something else that has the same side effects. Why do we do this? Because sometimes there can be allocation groups, right? So sometimes people might know each other and they might say, "Oh, I'm facing this with the research," you know, and these research might go on for years and years, right? So they might talk with each other and they might be like, "Oh, I'm facing these side effects," and then the other person will be like, "Oh, I'm not facing any side effects. Must have been the placebo then," and so that might kind of skew the research. So that's what active placebo kind of eliminates. Okay, so that is active placebo. You need to give similar side effects. RCTs, randomized control trials, they are the gold standard for establishing cause and effect because directly it's a trial, it's an intervention that you give and you measure the outcome. So that's the best measure of cause and effect. Okay, you need to know that it's rigorous and it directly measures cause and effect. This is also from the MCQs. Okay, one thing that prevents bias in randomized control trial and why it's so good and the gold standard is because of the random allocation and the blinding. So random allocation means that you're going to randomize the groups. There is not going to be anything that helps you choose people you want to treat and people you don't want to treat or want to give placebo. So that's like true randomization that helps minimize bias. And another thing is blinding. So blinding can be of different types. So it can be single-blinded, double-blinded, and triple-blinded. Single-blinded is where the patient doesn't know if they're receiving the treatment or the control. Double-blinded is if both the patient and the doctor doesn't know whether they're receiving the treatment or the control. And triple is the doctor and the patient and the statistician who is doing the statistical analysis for the research doesn't know whether they're receiving the treatment or the control. Okay? So that is single, double, and triple-blinded. Another thing, this is a phrase from the MCQs as well, is exclusion is done before randomization, withdrawal is done after. Okay, so exclusion criteria for any randomized control trial is something that you decide before you start recruiting patients. Okay, so you would say for my research, I don't want anyone under the age of 18. Okay? So you're going to exclude them before you randomize all the patients. However, if the patients who are above 18, they enter the study and then they don't want to follow up with the study and they withdraw, that is after randomization. Okay? So that is the difference between exclusion and withdrawal. Exclusion is something that we do before randomization. Withdrawal is something that the patients do after randomization. Okay. And one extra thing that might be important is that this is important because withdrawal sometimes has to be taken into account for when we do something called intention to treat analysis. So intention to treat analysis is basically after you've collected all your information and some patients dropped out, whatever, you have most of the information, you analyze them as if you treated everyone. And you don't take into account the people who withdrew from the study. So this is intention to treat. Anyone that you intended to treat will be included in the analysis. I hope that makes sense. Okay, it's a type of analysis that's done in randomized control trials and it gets rid of biases sometimes. Okay. Group of patients with lung cancer is matched to a group of patients without lung cancer. Their smoking habits over the course of their lives are compared. On basis of this information, researchers compute the odds of smoking among patients with lung cancer compared to the odds of smoking among those without lung cancer. This is an example of, this should be very obvious, it's an example of case control study. Okay, this is very important. Why? Because we're checking people with the disease. Our population is patients with lung cancer. So they already have the disease, which is our case. We're comparing with patients which are controls, which are patients without lung cancer. We're calculating the risk, the odds ratio, control the case in the OR. Okay? Or OR stands for odds ratio. So this is going to be a case control. Again, 500 women aged 40 to 54 present for routine checkups, are asked about their meat consumption. 20% turn out to be vegetarian. During the ensuing 5 years, 5 vegetarians and 43 non-vegetarians develop colorectal cancer. Which of the following best describes the study design? So this is going to be a cohort study. Why? Because uh, we are actually before I say that, can you tell me whether it's retrospective or prospective? It is going to be a prospective cohort study. Why? Because we are first starting with the exposure. What is the exposure? The exposure is vegetarianism or meat consumption. Okay, then we follow up with them throughout 5 years and see whether the outcome, which is colorectal cancer, develops. And that is the basic framework for cohort studies. Okay, study was done in a hospital ward for an infectious disease. Hospital wards with improved quality of hygiene are compared with other wards not on improved care. Okay, baseline data and were taken and then reevaluated a year later. What kind of study is this? Okay, I believe this is also a cohort study. Mm, if I'm not wrong. Yeah, this is also a cohort study. So here we're taking exposures again. So what do you call it? We're comparing increased quality of hygiene with another group that has a decreased quality of hygiene. And we are doing this, and then what are we finding here? Yeah, infectious disease. Baseline data were taken. Yeah, basically, we're trying to find, I think this question is incomplete, but we're trying to find out the rate of infectious diseases, basically. So we're going to try to reevaluate them a year later. So again, this is a prospective cohort study. So we have patients on, wards with improved quality of hygiene, wards with decreased quality of hygiene. We follow them up for 1 year, calculate all the demographics and everything, and see their rates of infectious disease. Okay, so this is cohort. All right. So, new drug, in vitro activity, HIV, out of the 200 individuals, 100 are chosen in a lottery to receive the drug. The drug, which is tasteless, administered in a cup, the other patient receives pure orange juice, blah, blah, blah. This is an example of a double-blind randomized control trial, for sure. Because nor the patients know which patients, neither the nurses, doctors, nor the patients know which patients have received the drugs. So this is double-blinded. It's a randomized because they're chosen by lottery, and it's a clinical trial because you're using a drug here, basically. What is the drug? We don't know the drug, but it's administered in a cup of orange juice, so they're trying to blind the people to the type of drug that they're receiving. So this is going to be the blind randomized control trial. 17 articles analyzed on postpartum depression found that compared to control, treatment lowered depression. Which of the following is the type of study? So this is going to be a meta-analysis. How do I know that? Because there are 17 articles that they analyzed. So it's a combination of other research that they're comprehensively putting together. And they also have a statistical analysis done, okay, which is P less than 5%. So they found a statistically significant effect. Okay, so this is going to be a meta-analysis. Okay. Now, there's a few things about the Cochrane Library. I've seen a few questions about it too. It just basically says that how Cochrane Library is a very good resource. There's a clinical answer part of it as well. There's a library part of it. So they publish a lot of systematic reviews. Basically, anything good option that you see regarding Cochrane Library, that's probably the answer. So it's a combination result of a lot of reputable medical research studies, and it helps with evidence-based medicine. So which of the following statements best describes the Cochrane Library? High quality, reliable evidence, basically anything that is good. Okay? Okay, which of the following represents combined results of a systematic review database for randomized controlled trials? That's going to be Cochrane Library. Again, they publish a lot of good systematic reviews. Okay, then we move on to critical appraisal of research. So we're in step 3 now. Okay, so critical appraisal of research, it is to judge the external validity and the internal validity. What does that mean? External validity is the generalizability. So you did a study and you found out that smoking causes lung cancer. Okay, how are you going to apply this to the general population? Are the patients who are in your study similar to the patients who are in the general population, and or not? Okay, so this is how you can critically appraise a research. So you're going to ask yourself questions to assess whether or not your research can be applied to the wider population. Okay. Then internal validity is the degree to which the study is done properly. Okay, so you said that smoking causes lung cancer, but did you measure anything else within your patients that could have also caused lung cancer? In other words, did you remove any other confounding variables? So that's going to affect the internal validity of your research. And then how did you establish lung cancer? Was it through chest X-ray? Was it through any markers, like tumor markers? Was it through biopsy? Did you use a proper technique or a proper diagnostic tool to diagnose lung cancer? Right? And then smoking. What type of smoking? Was it like actual smoking? Was it vaping? Was it other sources of nicotine? Or was it tobacco? So stuff that could affect the your research or the kind of strength of your research is the internal validity, and how your research applies to the wider population is the external validity. Okay. All right, so evaluating RCTs are important to measure the efficacy and the effectiveness. So this also ties in with the internal and external validity, but I just thought it would be important to understand the difference between efficacy and effectiveness. So efficacy is the how good the study is. So the internal validity. If smoking causes lung cancer, okay? Sorry. We're talking about RCTs actually here in efficacy or effectiveness. So it's more about drugs. It's not about whether smoking causes lung cancer or not. Maybe let's say for breast cancer and hormone therapy. So tamoxifen, one of the hormones, whether or not it treats breast cancer. Okay, so efficacy would be that yes, it treats the breast cancer. Effectiveness would be how well it treats the breast cancer. It would be taking into account everything else. So how effective is it in treating a breast cancer and improving the quality of life of the patient? Okay, so efficacy is the maximum benefit, or this is something we took in pharmacology as well, efficacy versus potency. So efficacy is the kind of the maximum benefit that a drug can have, whereas effectiveness or potency is kind of the slope or how steep the how steep the efficacy is, or how good the drug is. I hope that I explained it correctly. So efficacy is the absolute kind of this helps this. Effectiveness is it takes into account everything else, is the wider generalizability. So again, the external validity of the population. Okay, I hope that makes sense. So high quality RCTs, I suggest that you give this a read. So it should have clear objectives, randomization, blinding, intention to treat, accurate sample size, etc., etc. Okay, which of the following are the reason, is the reason randomized controlled trials are used in pediatrics? So the answer here is going to be B. RCTs are the gold standard, as I mentioned. Okay, so a study involves tracking individuals diagnosed with uterine dysplasia to observe changes in their condition over time. Which of the following type of study design does this scenario represent? So this is going to be case series. Anytime you see the word individuals, always have the top choice in your mind should be case report or case series. So here, since it's a bunch of individuals with uterine dysplasia, then it has to be case series. Okay, it's always going to be something very unique, a unique disease, and something that has to do with individuals or one individual. Okay, again, observational descriptive doesn't make sense. Um, you're following up with them. Usually observational, cross-sectional, those studies are snapshot in time. Meta-analysis, you're just observing changes in time. You're not really comparing with anything. And experimental, there's no experiment done here. Okay, so evidence-based medicine and CPGs. Again, this is something to understand logical, as one might say. CPGs is basically when you do research and then you convert them into practice guidelines or guidelines that you can use in your own clinical practice. Okay, how do you do this? There are a bunch of steps that you can see in your slides as well. I didn't really include them because I didn't feel the need to do so, but one important step is to use the grade system. So what is that? Is grading of recommendations, assessment, development, and evaluation. So these are the four steps that you use in order to convert something that is evidence-based or a research to your clinical practice. Okay, so what are the objectives of clinical practice guidelines? It's to improve patient outcomes, reduce unwarranted variations because research changes all the time, but you can't really change your guidelines all the time as well, right? So, I mean, you can, but it will, if you have a proper way of making that change, you reduce the unwarranted variation in clinical practice, okay? And it's obviously evidence-based. Okay, there are again barriers to this. So there can be clinician-related barriers, organizational barriers, and patient-related barriers. So clinicians might not Well, if I'm practicing for 20 years and I gave one drug for hypertension, and suddenly you're telling me, no, you have to change another drug which has a different dosage, it's an injection actually, and I might be hesitant. I might not want to change my 20 years of experience. I think I might know better. So that's what can happen. There can be clinician-related barriers. Clinicians might even not have enough time to go and research those options, right? So those are some barriers as well. Organization-related, it could be inadequate resources, again, rural areas. And then there could be patient-related barriers as well, such as cultural beliefs. We know a lot of people who, even though all the evidence suggests that, you should provide vaccination, some people are against vaccination, right? So there might be cultural beliefs, there might be educational beliefs, low health literacy, and etc. Okay, so the grade system is primarily used to, it's going to be B, grade the strength and quality of evidence for recommendations. Okay, so this is again the same thing. All right, which of the following best describes the main aim of step 5 of EBM? So again, the 5 steps. It's going to be B. Assess how well the evidence-based decision worked in practice. Okay, so 5 is assess. So let's see if we can remember. Let's see if I can remember. So it's ask, acquire, appraise, apply, and assess. Okay. All right. How to assess your performance? Yeah. So in clinical practice, not the sweater business, how do you assess that you're doing well? Well, you can have audits. Audits are kind of meetings that you have with your uh, what do you call it? You have with your department, and you see whether or not your guidelines that you have in place are working with your patients, right? And those you can use those to assess your performance as a department as a whole, and you can make changes. Otherwise, it could be even smaller. You can do it yourself. You can measure the outcomes of your patient, whether they're adhering to the medication, whether they're satisfied with the medication. Okay, then you can also have peer reviews where other clinicians or experts in your field kind of measure the rate of success of your things. And you can have self-reflection, which is basically just look at your patients, see if you're doing a good job, if there's anything that you need to improve on. Okay, so quiz again. Which of the following methods is most appropriate for assessing performance? Okay, it's going to be D. So D is the only one that makes sense with step 5. Delegate the assessment to non-medical, of course not. Conduct a randomized control trial. Again, no. That's going to be in, I think, acquiring. No, no, sorry. That's going to be in step 3 or step 4, I believe, where you perform sorry, apply, yeah. That's going to be earlier steps. And then you have the repeat the literature search. That's going to be acquiring information. That's not the case. Delegate assessment to non-medical personnel. Again, no. All right. During the assessment phase, Dr. Hamza realized his diabetic patient did not improve as expected despite following the guidelines. So which of them is going to be C, reflecting on his clinical decisions and following up? Okay. All right, so we're moving on to another very important part of evidence-based medicine, which is ethics. So ethics is the study of values, principles, and beliefs. I say this because you need to know the definition sometimes for the MCQs. Okay, conflict of interest is anything that is a financial or personal interest which could potentially get in the way or bias the professional judgment of the researcher. Okay, we're going to see examples of this later. These are again terminologies that I've put this here, although I don't like reading from the slides, but I put this here because these are exact words that come in the MCQs. Okay, so we know research it's an organized investigation. Basically, IRB, it's a local ethics committee that kind of oversees research or potential research projects. Informed consent, it is in a way through which a researcher obtains a permission of a person to be in a part of or participate in the study. Then we have principal investigator. It is a person responsible for overall administrative, like they do most of the work. Sorry, no, no, no. Principal investigator is the person who is responsible for the administrative or scientific or technical direction of the work. It's usually the doctors. When we do research, it's usually the doctors, basically. Um, when students do research, I mean, it's usually the doctors that serve as principal investigators or the more experienced people in the field. Compare this to what's the other one? Corresponding author. Corresponding author is the person who you do your kind of contacts with. Okay, so they will be responsible to contact the journal, have all the back and forth email, respond to any emails from the journal. So that's the corresponding author. Principal investigator is what I mentioned. First author is usually, it's done in terms of how much effort they put in, the order of authors. So the first author usually does most of the work, followed by the second, followed by the third. Okay, we all know what anonymity is to remain unidentified, and it's very important. Confidentiality is to make sure that collecting data is done securely, and participants' information is done collected in a way that protects their identities. Okay, what are the fundamental principles of ethics? It's autonomy, beneficence, non-maleficence, and justice. Autonomy is respecting a decision that a patient makes, okay, or a research participant makes. Beneficence is always doing something that is good for the patient. Non-maleficence is not harming the patient. Justice is to treat all people equally, fairly, and impartially. Okay, so which of the following best describes the principle of non-maleficence in ethics? So it is to avoid action that causes harm to others. So non-maleficence means basically do no harm. Okay? Oh, the answer was here actually. Okay. All right. Then we have something called research misconduct. So there are two types of bad things in research, basically. One is research misconduct, one is unethical research practices. So research misconduct, the only difference between them is that research misconduct is illegal. Unethical research practices, they're legal technically, but they're just a bad thing to do. They reduce the quality of the research. And it's a morally gray zone, basically. You wouldn't want to be the person who does an ethically wrong research, you know? All right, so let's go more into them. Research misconduct can be of three types. You can have fabrication, falsification, and plagiarism. Okay, so fabrication is making up data or making up results and publishing them. Falsification is manipulating research materials. So fabrication is kind of making results appear out of thin air, and falsification is, let's say, vaping causes lung cancer. I'm really stuck with that explanation. Vaping causes lung cancer, but let's say I vape. Okay, so I'm going to say, no, I'm going to falsify my results and I'm going to publish them. Okay, so that is what falsification is. Then plagiarism is taking someone else's work and putting it as your own. So that's the simplest way to put these things. I hope that makes sense because it's very important for the exam. So the difference is research misconduct is legally defined. It has a formal investigation if it happens, and it has legal penalties or funding losses. Unethical practices, they're a broader violation of professional standards such as these. So if you submit the same paper to different journals or if you exploit vulnerable populations, I think I removed that slide. Yeah. So vulnerable populations such as populations in prison or children or pregnant women or yeah, those are vulnerable populations or maybe intellectually or mentally disabled people. Yeah. And then there are other examples of unethical research practices, but I think you get the idea. Okay, which of the following terms refers to a local ethics committee established to review and approve research projects that involve human subjects? So that's going to be the IRB. Okay, you can read the definitions that are before. Okay, which of the following term refers to a situation in which a financial or personal consideration have the potential to compromise bias? That's going to be conflict of interest. Which of the following is the process through which a researcher maintains permission of a person? That's going to be informed consent. Which of the following describes plagiarism? It's going to be using another person's data or ideas without giving them credit. Okay, manipulating research data is going to be falsification. Making up data is going to be fabrication. And yeah, okay. All right, we're reaching towards the end. Not really, but slowly but surely. Okay, so there are a lot of different reasons why someone can have conflicts of interest, and some of them may show up in your exam. So there can be financial. Let's say I get paid to do a research, I will be more likely to publish the results of that research. Okay, so let's say if a drug company pays me and tells me that if you say in your research that my drug treats all kinds of cancer, I'm going to give you this amount of money. So I'm going to be more inclined to publish those kind of results. Okay? So those can be a conflict of interest. So also if the company influences my study design that I choose of comparison groups, so let's say they'd say choose a certain comparison group that makes it more obvious that the drug works or something like that to manipulate how the study works. Okay, publication bias, as we mentioned, that can be a conflict of interest because some research might only receive funding if they publish. Okay, all right. Now, IRB, there are three different kinds of IRB approval. So there is an exempt review, there's expedited review, and there's full board review. IRB is done to gain acceptance of or like permission to do a research, right? So when do you get exempted from IRB? If a research is conducted for educational purposes, tests, surveys, interviews, except if the information is recorded in a manner that reveals the identity of the person, or if they are using this person outside the scope of the research to be subject to criminal or civil liability. Again, like these are things that you just kind of understand, and once you understand, you can be able to recognize them in the MCQ for sure. It's not going to be that confusing, inshallah. Okay, all right, so that is exempt review. Let's just do this question. What is this primary function of an IRB review? Okay, so this is going to be B, issue approval to conduct research from an ethical aspect. Okay, expedited review, it's basically done by some IRB members, not all, but not the full committee. Okay, so this is done for research which has minimal risk. What is minimal risk? Again, very important definition. It is the level of risk that is no greater than the risk encountered in daily life. So we encounter a lot of risks in daily life. Every time I go to, let's say, plug in my laptop charger, there are some risk that it might spark, right? So that is going to be a daily risk. So these minimal risks, if the research that I'm doing is similar to these minimal risks, no higher or no lower, I mean, lower you can't really, no higher, then it can be subject to an expedited review where only one or two IRB members do the review and not the whole committee. So this is going to be retrospective chart reviews, non-invasive collection of tissue, such as like from the inside of the cheek, and minor revision to an already IRB approved paper. Full board review, now this is where you require the entire committee. This is done in studies which have mild, moderate, or high risk, not minimal. In other words, like more risk than we face in daily life. And if the study involves protected populations, such as prisoners, mentally challenged or physically challenged people, pregnant women, minors, etc. Okay, so what is minimal risk? The answer is going to be B. The level of risk that is no greater than the risk in real life. Okay, then we move on to research proposals. Research proposals are basically a plan for the project. And why is it done? To obtain IRB approval and to kind of have a plan for the project as well. Okay, what are the elements? So this is a lot of slides that I put together in one because, yeah, just to reduce the number of slides. That's why it might seem like a lot. Okay, so first, for any research proposal or yeah, any research proposal, you need to have a title page. The title page actually. So you can, it has to be a short, concise title. Short doesn't necessarily mean like short itself. It just has to cover everything without having too many extra things. Okay, has to have the main keywords and has to convey the main message. Then you have the abstract, which is a brief and structured summary of the research, and it has a specific format and a limited number of words. Now, for the abstract of any article, it can be structured or unstructured. Structured abstracts are seen more in basic research or randomized control trials or like big researches, basically. And structured, the abstract itself has introduction, background, significance, methods, results, conclusion. So that's in the abstract and it's structurally written. Whereas an unstructured abstract is seen more in case reports, case series, in reviews, and they're more written as a block of text. Okay, so it's a paragraph that kind of narrates whatever goes on in the research. So that's structured versus unstructured, if they ask. Then, after the abstract comes the literature review. Literature review is the opening paragraph. It tells you everything else that is published on this topic already, and it identifies potential gaps that your study plans to cover. Okay, then you have the methods. Methods, they state the study objectives. Okay, they describe the study population, who are you studying, and what statistical methods you're going to use, how are you going to collect the data, how are you going to measure the outcomes, right? Then you have your references, obviously, very important that you put the references according to the format of the journal. An appendix if you need to mention anything else, the budget, any conflict of interest, roles and responsibilities of the research team, etc. I think by now all of you must have been and part of one or two research projects. You guys are much more advanced than we were. So I guess most of you already know what's going on here. And then you have hypothesis. Any research has a hypothesis that the research is trying to prove or disprove, right? So hypothesis is a tentative assumption. So it's a assumption that I'm making that I think will work. And then I will do the research and see whether it works or not. Okay? So I think that vaping causes lung cancer. So I'm going to do a research on vaping and lung cancer and see whether they work or not. It must be a testable hypothesis. Again, feasibility, testability, very important, measurable as well. Okay? This is also something that comes in the MCQs. It's just one random thing, is that all research protocols must include a section addressing clinical ethical consideration. So sometimes they might ask, what research needs ethics? The answer is all research needs ethics, okay? All right. This is also something that comes in the MCQs, all three of these bullet points. So experts say that most proposals fail because of poor writing, formatting, and presentation rather than blemished science. Okay, so it's mainly because of poor writing and formatting and presentation. Okay, another thing I've seen a lot is that the abstract after the title is the most read section by people. So people read the abstract the most because it provides a small summary. Then introduction and literature review contain the most references, obviously, because you're going to try to summarize everything together about the previous research that has been published on these things. So then clinical versus translational research, this is more of a definition. Clinical research is when it involves people, data, or samples of tissue. And translational research is basically basic science research that you are kind of translating to clinical practice. So that's like doing studies on rats and then transferring that data to humans. Okay, that's translational research. Okay. Uh, Sorry, that's here by mistake. Okay, data versus information versus news. So data is individual facts, information is organization and interpretation of those facts, and news is information you didn't know before. Okay, so for example, the yellow spreadsheet thing that you're seeing, this is a collection that we had to do for one of the research projects. And this is very messy. It's in the form of spreadsheet. You don't really know how to make sense of this. So this is data. It's something that is raw, just info, raw, but not information. However, when I sit down and interpret this information and write down a proper result section, that is going to be information. Okay, so this is data, this is information. I believe that brings me to the end of my PAL session. Thank you so much for joining. I really tried to keep it as concise as possible and did not change as much because I really don't think this um, course requires much of it. Thank you so much for joining. Please just, if you have time, just go, if you really, if you have time, go through the slides, read it once, you'll be able to understand it. If you don't have the time, you can also go through my condensed version of the slides. It's basically all the slides almost. And whatever is not there is either I've never seen them in the exam or um, just I've condensed them into other slides. Okay, that's it. Thank you so much for joining. And if you have any comments or any suggestions that I can use to improve myself in the future, feel free to let me know by scanning this QR code. Yeah, any comments, any feedback, good or bad, I guess, let me know. Thank you so much. Good luck for your exam. All the best.